2023 regular meeting of the Washington Township Healthcare District Board of Directors. I'd invite you all to stand with me and join in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person in the boardroom at 2000 Maury Avenue, Fremont, and is also accessible by Zoom. I ask that you mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting, and it will be posted on our website for future viewing. Cheryl, if you take the roll for us, please.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Wallace.
Present.
Director Yee.
Present.
Director Eapen.
Thank you, Cheryl. Moving now to oral communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none. Cheryl, are there any written communications?
There are no written communications.
Good. We'll move on to our consent calendar then. I'll entertain a motion on the consent calendar.
Yes, Mr. President, I move that the board of directors approve the consent calendar, item A. Second.
And a motion and a second. Cheryl, if you take a roll on that, please.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Yee.
Aye.
Director Eapen.
Thank you. That motion passes. We'll now move to our presentations. Kimberly, if you'd like to introduce that for us.
Yes, this evening, our first presentation is the Community Health Improvement Plan for 2024 and 2020 through 2026. And this is a follow-up to the discussion that we had at one of the previous board meetings about the Community Health Needs Assessment. And so once again, we have Angus Cochran and Kayla Gupta here, and I will do a short introduction for both of them. Angus Cochran has been with Washington Hospital Healthcare System since 2006 and currently serves as Chief Community Support Services. In this role, he is the liaison to the Service League and manages community outreach and the Health Insurance Information Service. He is also responsible for governmental relations for the healthcare system. Angus earned a bachelor's degree from UCLA and a doctorate from Columbia University. Next is Kayla Gupta. She has been with Washington Hospital Healthcare System since 2022. As our community outreach manager, Kayla is responsible for the health and wellness programming and the Washington Wellness Center. Before joining Washington, she worked with Sutter Health as a community benefit coordinator. In this role, Kayla managed the Community Health Needs Assessment and Grant-Making Program in San Mateo and Santa Cruz counties. She earned her bachelor's degree from the University of Pennsylvania and a master's degree in public health from Emory University. Kayla is married with one young son. All right, thank you both, Angus and Kayla. I will turn it over to you.
Well, thanks so much, Kimberly. And thank you so much to the board as well for inviting Kayla and me back to present the 2024 to 2026 Community Health Improvement Plan. I feel like we're a pair of bad pennies. We keep showing back up at the board meetings to give presentations. But we're really excited to lay out this 3-year plan with the scope of work that's intended to respond to the findings from the 2023 Community Health Needs Assessment that the board approved back in May at your board meeting then. Before I turn it over to Kayla, I just want to point out a couple of things, a couple of significant aspects of the plan. The first thing to point out, of course, is it is a plan, and like all plans, it will inevitably change as we learn more about the health needs in the community and as things change on the ground over the next 3 years. Second, we've limited the presentation here to illustrate many of the current initiatives that are underway or planned. So what you'll see this evening is not an exhaustive list of all the activities being undertaken, but they're kind of selective of the ones that are most topical at the moment. Third, you'll also hear that we're paying particular attention to addressing health disparities within the district that impact communities of color and residents with disabilities. And this is really in keeping with the health system commitment to health equity and inclusion. And fourth, we're laying out a specific plan you'll hear about of action for Union City. And this is really where we found that there are significant health disparities with the city residents in Union City. In short, the health of city residents has fallen behind that of Alameda County residents on a number of health indicators. And I think this is an area where we can make a big impact. The fifth thing is that we really developed this implementation plan through conversation with internal partners in our clinical areas. We are really, really grateful and lucky to have such wonderful clinical partners like in stroke care, oncology, diabetes education. And we've also spoken to a number of external community partners as well to get their feedback. And that process will be continuing on in the next few months as well. Clearly, for this plan to have the impact we intend, we're going to have to collaborate with other organizations, advocacy groups, local agencies, the 3 cities in our district, and the faith community to reach more populations that have health challenges. And then the final thing I want to point out, we're not going to address all of the 8 health needs that we prioritized in the community health needs assessment. It really is too large a scope, I think, for what we can do in order to move the needle on some of these health conditions. So we're going to focus on 5 of the health needs where we believe we can have the greatest impact on health outcomes. For the other 3, as you hear from Kayla, we're really going to partner with advocacy groups on those health needs, with groups that focus on housing and homelessness, economic security, and respiratory health. So with that, I'd like to turn over to Kayla, if you could walk us through the plan. Thank you.
Great. Thank you so much for the introduction, and thank you so much to the board for having us this evening to present. It's wonderful to be here with you all again. So I can go ahead and kick us off on our tour of the 2024-2026 Community Health Improvement Plan. I'll also refer to this as the CHIP for short throughout the presentation, because that is quite a bit of a mouthful. So we can move ahead to the next slide, please. Thank you. So today we're really going to focus on taking a look at the CHIP, but before we get into the meat of the presentation, I'd like to just touch on the CHNA, our Community Health Needs Assessment, again as well, to help refresh all of our memories about the findings of that report. We can move ahead, please. So as a reminder, CHNA and the CHIP is something that we're federally mandated to do every 3 years. And this is a way to help us provide insight into the health of our community and create areas of focus where we can develop key strategies to move forward. It's something that we do to stay relevant. It's something that we find very meaningful work. And so we'll walk through that just a little bit more on the next slide. Before I dive into our health needs and our response, I just wanted to take a moment to remind everyone that the cycle that just ended was really disrupted by the COVID-19 pandemic. We needed to really focus and pivot to respond to the needs of the pandemic, which meant creating new initiatives around COVID-19 education, switching to put programming in an online virtual format, and really playing a key role as a trusted source of information for testing and treatment during that time. Next slide, please. So before we jump into those key initiatives that we planned, let's take a moment just to review what the 2023 CHNA revealed. So as you can see here on the slide right now, these are the top needs that we identified through data and discussion with community members. So we found our top key areas to be behavioral health, housing and homelessness, economic security, diabetes and obesity, heart disease and stroke, healthcare access and delivery, respiratory health, and cancer. We're briefly going to take a look at the snapshots for each of the cities in our district. And just as a reminder, we were able to aggregate disease incidence data for each of the 3 district cities. And for all of the conditions that have bars pointing to the left, that shows that there is less prevalence than the county average Anything to the right would be more prevalence than the county average. And so the good news about Fremont is that all of the 25 disease states are showing below the Alameda County average. That being said, diabetes, cardiac conditions are still near the county average. There's still opportunities for improvement, but overall, Fremont is doing a really great job. On the next slide, we'll take a look at Newark. And Newark has only 4 disease states that are greater than the county average this year. On our next slide, we'll see Union City. And unlike Newark, Union City residents have failed to keep pace with the county. So in 2020, we had 12 disease indicators that were worse than the county. In 2023, there were 13. So it's actually a bit of it's gone down over time. And so this just shows that there's a lot of areas for opportunity for partnership and programming, as Angus talked about in his opening remarks. Now, we at Washington Hospital know we're not the sole source of information and knowledge, and it's really important for us to partner with our community and local organizations to fully understand and serve the needs of our district residents. So in creating this plan, we solicited feedback from the community on different strategies to address the key health needs that we identified in our CHNA. And you can see a list of those organizations that we got feedback here on the slide. After speaking with them, I'll show you on the next slide the key health needs that we plan to address in the next 3 years. And so, as Angus mentioned, these are needs that we're going to directly address, ways that we can really make an impact significantly in the community, given our resources and our expertise. We'll talk about the other 3 as well at the end of the presentation, because there are ways that we can work in our community to address those as well. But for now, I'll really focus on behavioral health, diabetes and obesity, heart disease and stroke, healthcare access and delivery, and cancer. So let's move on to our first health need that we've prioritized, and that's behavioral health. So just a quick recap for you all of what our CHNA revealed. And as a reminder, the shaded boxes are areas where the conditions are worse than the county average. And so as you can see, Newark and Union City are more heavily impacted when it comes to alcohol and drug use. We also had a lot of community input and concern about lack of access to behavioral health resources. Moving on to the next slide, you'll see a list of initiatives. And as Angus mentioned in his introduction, for each of these prioritized needs for the CHIP, we've listed some of the most impactful initiatives that are ongoing right now. This is not in any way an exhausted list. We just wanted to give you a sense of the work that's already underway. And so, for example, for our behavioral health, we're really proud to provide a social worker for the City of Fremont Met team, which goes out on site to do outreach for individuals in mental health crisis, particularly those living in encampments. We also help convene our South County Partnership, which has representation from all of the cities in our district, as well as around 10 nonprofit organizations that are very concerned about behavioral health. We also have an extensive network of nonprofits that we share resources with and that we can rely on for support, like our partnerships with BayWire and SAVE to help with patient advocacy for intimate partner violence cases that present in the ED. But in addition to the work that's already going on, I wanted to give you an idea of some of the things that we're planning to address for behavioral health needs. We know that opioid use is a significant factor in behavioral health. And as we saw in our data recap, Newark and Union City had higher rates of drug use in the district. And so we're planning to work with Holler's Pharmacy, particularly in the Newark Unified School District and New Haven Unified School District, on education around fentanyl and naloxone. We're also collaborating with the county to host a space for an outpatient behavioral health clinic. We're hoping to see this program launch in the first half of next year. In addition, Washington Hospital has received a grant that will help cover the startup costs for a pilot program of a substance use navigator in the emergency department. Moving on to our second health need is diabetes and obesity. So looking again at the data from our health needs assessment, we can see that Newark and Union City have higher rates of diabetes-related ED visits and higher rates of childhood obesity. We also see that diabetes is more prevalent in our Asian and Black communities. And so diabetes and obesity is not a new health need for the district. This is actually something that we've been working on for many years. It's something that we talk about often in our health and wellness programming, and it's a key focus in our health fairs. We have at least one seminar every quarter that talks about healthy cooking, maintenance of diabetes, healthy lifestyle. And additionally, through our wellness center, we offer affordable fitness classes to keep our district residents healthy and active. But in addition to the work that we're already doing, we have some initiatives that we're laying the groundwork for right now. And some of that is implementing an on-site farmers market or a pharmacy partnership with our local food bank, exploring offering additional online resources for our diabetes patients, since we know we have a lot of material that can be made accessible online. And because we saw disparities pop up in our CHNA report, in order to address those, we're planning to collaborate with partners that serve our Black and Asian communities, especially our faith communities, to provide targeted diabetes education. The third health need that we'll be focusing on is heart disease and stroke. And as a reminder, our CHNA showed that Union City is disproportionately affected by cardiac conditions and stroke. We already have an incredibly robust set of resources that we offer our community for heart disease and stroke. It's one of the core things that we do in our outreach efforts. In all of the channels where we reach people, whether it be through health fairs, our health and wellness series, school presentations, presentations at senior communities, we really have a lot of great outreach going on right now. We also host our support groups for on heart disease and stroke in addition to that. But one thing that we saw in this CHNA is that there really is a large impact of heart and stroke conditions in Union City. And so in order to address this head on, we're planning to host a Heart Health Summit in Union City, where we can focus on providing education as well as clinical screenings such as cholesterol, blood pressure, and aneurysm screenings. Also, we're looking to offer education in schools about heart health and stroke, since what we hear from our stroke team is that students are really the best way to get key health information about stroke into a household and educate the whole family about the importance of BFAST and stroke symptoms. The fourth need that we'll be addressing is focused on healthcare access and delivery. And I'm sure all of us recognize that in healthcare, we've come to an understanding that there are multiple ways of providing care to different communities. Healthcare systems across the nation, we can all do a better job about being more effective in how we communicate with our district and treat patients from different cultural backgrounds. Healthcare access also means being able to get insurance and navigate care. And Washington Hospital already offers programs to help patients through our health insurance information services, to connect with insurance, to connect with a doctor and navigate the healthcare system. We ensure that district residents have access to medical equipment and medical garments through our lymphedema garment program and our partnership with ReCares. But the big initiative that we're doing to bring healthcare services to the district is standing up our trauma service. This is a project for the next couple of years. And in the short term, we're planning on education in the next year on Stop the Bleed and preventing geriatric falls. In an effort to make patients more comfortable in receiving care and to eliminate hurdles to receiving care, our work over the next few years is really going to be focused on inclusion. And so some of those strategies involve creating a patient family advisory council that's made up of patients and family members to help give us feedback, and really to offer more programming around diversity and inclusion for our staff on delivery of care. Our fifth and final health need that we're focusing on is cancer. And at a first glance, when we look at the district as a whole, we're on par with the county for cancer incidence. But when you dig into the data, that's when we start to see those significant disparities pop out. So for example, we find that white women are more impacted by breast cancer, Black men are more impacted by prostate cancer, and the white population overall is impacted by cancer of all types. Thankfully, Washington Hospital already has a great and very strong partnership with UCSF that allows us to offer cutting-edge cancer care to our community and our district residents. We also have a wonderful team that's dedicated to providing health education at health fairs, senior centers, faith communities, and through our wellness programming. We host support groups, and we do partner with local clinics to offer free mammograms for those without insurance. So there's already some great work going on around cancer. This last slide will be the last slide outlining new initiatives. And so I just wanted to speak a little bit to how we're going to, address disparities that we found. And so one of the ways that we can work on this is to create partnerships with organizations and our faith community to really reach underserved racial and ethnic groups. This is the case that we saw for breast cancer, but I also believe there's some good work that we can be done to target prostate cancer in Black men. So creating a men's health summit in partnership with those partner organizations to really put an emphasis on promoting preventative screenings is something that we're really excited about doing in the coming years. I also want to mention, we're going to be going through the expansion of our cancer center, which is just going to be a wonderful service for our district residents that will increase access to more care and cancer trials. Before I wrap up, I really want to address how we're going to focus on our efforts in Union City. So that's why I've pulled up this slide again that shows the snapshot of the health in that city. And as a reminder, we showed concerning differences for 13 of the
7 5 4 1 0 8 4 is not available. At the tone, please record your message. When you've finished recording, you may hang up or press 1 for more options.
So unfortunately, we did see a decline in the health from our 2020 CHNA to 2023. Before they were lagging behind on 12 indicators. Now we see 13 indicators where there's areas for improvement. So moving on to the next slide, it will show how we plan to focus our work in Union City. If we could just move on to the next slide, please. Thank you. So we'll plan to focus our efforts in 3 large buckets of health conditions. So we'll be focusing on cardiovascular health, behavioral health, and diabetes and healthy living. And the great news is that we have many community-based organizations with whom we can partner with to provide outreach in underserved areas like Dakota and Alvarado neighborhoods. And many of the organizations
0 7
here
5
already
4
expressed
1
enthusiasm
0
on
8
partnering with us on
4.
outreach opportunities. Thank you. So moving on, I just want to announce no hospital can address the health needs of its community alone. For these 3 remaining health conditions, Washington Hospital is really planning to drive our impact through partnership with local organizations. So for housing and homelessness, economic security, and respiratory health, we'll be focusing on partnership to address those needs. And as you can see on the next slide, this will show you a look at some of the organizations that we already have relationships with to begin that work in that partnership to address those needs. Before I wrap up, I just want to, you can go ahead to the next slide. I just wanted to thank all of my fabulous colleagues who've been just excellent partners in bringing health education to the community. I also wanted to thank the board, our CEO, Kimberly Hartz, for supporting all of our community outreach efforts. We couldn't do this great work without you all. And just pause to ask what questions you all might have.
Nope, no question, but a comment. I thought it was really great that you're reaching out to the schools to help educate the students. Because if we're really going to move the needle on cardiovascular disease and diabetes, it really requires changing the behavior of the target population. And a lot of those behaviors are pretty well entrenched. And so getting the students to look after their parents, and more importantly, their grandparents, as far as monitoring blood pressure, following the sugars, encouraging diet, encouraging healthy activities and exercise, I think will go a long ways to improving the health status of those folks in Union City who are at highest risk from cardiovascular disease and complications of diabetes. And I think really focusing on the young ones to help teach the older ones who might not be so willing to listen. I think they listen better to their kids.
Yeah. Thank you for that comment.
Kayla, I enjoyed that presentation. It's very, very wonderful presentation. It shows the hospital's outreach to our communities, and very, very nice presentation. I think it's probably, go ahead.
I just want to
I think it's probably appropriate at this point to take action on what you've presented to us. It's such a nice presentation, and I don't think you need to wait around for us to act on that. So I'll entertain a motion to approve the community outreach improvement plan as presented tonight.
Yes, Mr. President, I move that the Board of Directors vote to adopt the 2024-2026 Community Health Improvement Plan.
We have a motion and a second. Cheryl, if you take the roll on that, please.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Yee.
Aye.
Director Epen.
That motion passes. Congratulations to Kayla and Angus. Thank you very, very much
Thank you.
for all you've done there. Very, very impressive presentation.
Thank you, Dr. Stewart. I would be remiss if I finished this section without thanking Kayla for all the amazing work she's done on this report. This is really her work. So thank you for your dedication, Kayla. And thank you to the board.
Thank you again.
Yep.
Now the hard work begins.
Exactly.
now the hard work.
Yep.
Move on now to our construction update.
Yeah, so Ed Fayen is going to give an update on the construction for the patient bridge.
Thank you, Kimberly. So this is our monthly update, and I'm happy to report that we're functioning pretty close to on time, and we anticipate to be wrapping up by the end of December, and we've got a completion date of the latter part of January to be totally done and out of there. So things are moving well, as you're going to see in a minute. Okay, can we go to the next slide, please? You may remember, I think this is where we left off last time, where we were getting the drywall being placed, the drywall framing being placed on the bridge. That's been completed. You can see in the left-hand side, this is where the air handler is going to sit. And then on the right-hand side, you can see the beginning of the placement of the air handler on top of the bridge. Next slide, please. These are simply roof drains that have to occur all the way along the bridge, and you can see they're starting to hang.
0, 7, 5, 4, 1.
Starting to put hangers on for the pipes. Next slide, please. And then the piping goes in. You can see the connection to the roof drains. And then that's a condensate line for the HVAC on the right-hand slide. Next slide, please. And it just runs down to the sewer system below of everything coming out of the drains, the roof drains. Next slide, please. This is a completion of the sprinkler system underneath the bridge. There's also one within the bridge itself. Next slide, please. And this is the beginning of putting on this actually is not the waterproofing, but the layer underneath the waterproofing that gives some insulation. Next slide, please. They are working on the interior corridors. This gives you a shot of that to getting ready for drywall. Next slide, please. This is called mineral wool, and this is part of the fire stopping. So this is going to run the length of the bridge. It's painted over with that red paint after it's placed. And this is a fire stop. If there happened to be let's just say a car or a truck under the bridge that caught fire, this will keep it from coming into the building. And we actually have, as you know, the sprinklers on the underside that would also help then control the fire. Next slide, please. Now, this is the waterproofing that you can see is pretty well all in place now for the project. Next slide, please. These are curbs. This is on the Morris Hyman side, and these are curbs that are going to have drywall placed upon them, and they're part of the structure that's tied into the cab that's stretched out to the bridge, and that's going to be the seismic cab that's going to be moving back and forth in the event of an earthquake on just off of the Morris Hyman building. Next slide, please. These are windows and the window frame work that's starting to go into the building now. Okay, next slide, please. And this just gives you a look on the two sides of the building. So on the left is the view from the CJR corridor down the bridge, and on the right is the view from the Morris Hyman Pavilion looking down towards the CJR corridor. And I believe that should be the last slide. Next slide, I believe I'm done. I'll take any questions.
Thank you, Ed. Any questions from anyone on that? Pretty exciting to watch. Really is. When we first considered the bridge, I thought, well, you just put a bridge up.
You get to watch it go up.
But it's obviously a very complex situation. But nice to see it coming along.
Yeah.
It'll
Yeah.
be
So
fun to take a walk in it.
yes, when we're done. Yeah, so that'll be shortly. And budget-wise, we're still doing fine. I will tell you, we are going to go right up to the last penny as it stands right now. There's probably some chance that we could run over, not so much from the construction dollars. It's everything else. But right now, as we sit here today with 2 months left to go, it looks like we're okay, and we should be okay with budget unless we get hit with something that's unexpected.
Thank you very much, Ed. Appreciate that. It's always exciting to watch construction.
Yeah.
Thank you.
Thank you.
Really, we'd like to move on to the Veterans Day recognition.
Yes, I just have a few more remarks that I would like to make. I think every year, as we know, our nation celebrates Veterans Day as a way to honor and thank those who have served our country. At Washington Hospital Healthcare System, we proudly continue a tradition that we started in 2016. We recognize members of the Washington Hospital Healthcare System family who have served in the armed forces or are currently serving in the reserves by featuring them on a commemorative Veterans Recognition Wall. This wall is located in the Washington West Building. The wall lists the names, military branch, rank, and length of service of our veterans. I invite each of you to please visit the Veterans Recognition Wall next time that you are in the Washington West Building. The women and men listed on the commemorative wall are hospital and healthcare system employees and physicians. They are individuals who work in the hospital or one of our surgery centers. They could work in Washington Township Medical Foundation, one of our clinics, in one of our outpatient rehab centers, or other places. There are also doctors on our medical staff. Currently, there are 110 names on the wall, including 4 new names added this year. The following are the people who were added to the Veterans Recognition Wall in 2023. J. Rowe Jeffrey Nelson Barnett. J. Rowe is a surgical technologist 2 in our operating room. He served in the Army for 1 year of active duty and 10 years in the reserves. He achieved the rank of E1. Elwood Conaway. Elwood has recently joined our organization as the director of the trauma program. He served in the Army for 37 years and achieved the rank of 05. Napoleon Sonny Eberly III. Sonny is an Executive Assistant 3. He supports our Vice President and Chief Operating Officer, Larry Labossiere. Sonny served in the Army for 3 years of active duty and 3 years in the reserves. He achieved the rank of E4 Specialist. And lastly, Frederline Usita. Frederline is an RN in the Peninsula Surgery Center. She served in the Navy for 8 years and achieved the rank of E6. We should all be proud of the talented veterans who are part of the Washington Hospital Healthcare System family. Our leave policy allows members of the Armed Forces or National Guard to be granted military leave for work for the period required when called to active duty for training, in active duty training, or active duty. The selflessness of our veterans is valued and respected, no matter in which military branch these men and women served, or if they served in peacetime or wartime. We appreciate their service. We greatly appreciate the sacrifices they made to serve our country at home and abroad. Thank you.
Thank you, Kimberly. I'm very, very proud to be part of an organization that honors our veterans.
It is.
It's a wonderful, wonderful thing. I had the opportunity today to speak to a Vietnam veteran.
Did you? Mm-hmm.
And he's been, since his service, he's been married 50 years.
Wow.
And he said, it's taken a good woman to stay with me. But he does. He still suffers from many difficult things from his experience in that war.
And he's given a lot.
Yeah, and I gained new appreciation again. And I'm glad we're doing that here in the hospital.
Yep.
Thank you.
Next to a Vietnam War veteran.
Thank you for your service.
Thank you, Mike. You know, Paul, I remembered that, and I should have thought about that. It's an important thing.
Yeah.
Good. We're ready now for our reports. First of all, we'd like to hear from Dr. Soleil, our medical staff report.
Hi, good evening, everybody. That report by Angus and Kayla was excellent. It's great to see what we're doing for the community, and all really excellent things that are going to help out quite a bit. In the last few weeks, I've had the honor of participating in a couple of articles for local papers like the Tri-City Health, regarding prostate health and prostate cancer screening. I could imagine that that's part of this whole process, and it is being noticed. I had patients mention to me, in passing as I'm seeing them in the clinic, that they saw the article, or they saw what I said in the article, and it does make an impression. So that's great to see that. All right, I'm going to give you the census for the hospital. We have a total of 609 staff, of which we have 341 that are active, 2 administrative, 35 advanced practice providers, and the rest a mix of ambulatory, consulting, and courtesy, with some leave of absence. The aquablation program is ongoing. I did 3 more cases today, and we have several more coming up in the next few weeks. In fact, I was just in touch with Dr. Araj about finding more time in the operating room. The patients continue to do well, and the staff is getting more familiar with it and getting more efficient. So every day seems to be smoother and smoother, and that's great to see. Dr. Al Brooks, one of our own, was installed as the president of the ACCMA this past Friday at their annual meeting, and several hospital administrative staff and doctors from the medical staff attended the dinner in support of Dr. Brooks. Dr. Chet Morrison was there. Actually, he sat next to me, and we had a chance to talk about the trauma program, which he's still, even though he doesn't officially start till January, he is participating quite a bit until then, between now and then. in the near future, we have a meeting with him regarding organizing the trauma call. All the affected specialties that have to be on call for trauma are going to be meeting with him regarding how to work out all the details with that. And that is my report. Any questions?
Any questions for Dr. Saleh? Thank you very much, Dr. Saleh. Very appreciative of all you're doing.
Thank you.
We're ready now for our Service League report for Sheila Vijay.
Good evening, everyone. Good evening to all the board members and warm greetings from all the volunteers. So here I go with my numbers again. In November, 514 volunteers worked and contributed a total of 2,121 hours in line with our enduring commitment. My next announcement will be, I'm sure, very exciting for all of you. Our masquerade sale is happening on November 27, 28, and 29. It's really amazing that despite all the rising prices that we see, we continue to sell all these items for $5. To me, I think that's just amazing. So hope to see all of you there. Our gift shop will be closed on Saturday, November 11th, as we prepare for our upcoming holiday shopping season. We are excited to welcome you back when we reopen on Monday, November 13th. Please join us in the hospital lobby on that day, where we'll be serving cookies and coffee provided by Washington Hospital Employee Association, WIA, and Food and Nutrition Services. Thank you to both of them. Please don't miss the chance to participate in our raffle to win some wonderful items. This month, for my presentation, I'd like to travel through a part of our history. Our Puppets and Hankies group has a remarkable legacy that began in 1956, even before the hospital reopened. Back in 1956, when they started, these volunteers had already created hundreds of puppets. Today, they continue their dedicated work, making puppets and bonnets that are given to young patients visiting the hospital, bringing smiles and cheers to their faces. Next slide, please. Thank you, Sri. Here are some pictures of the volunteers who cut and stitch these puppets. And this one is not about that, but you can see that 4-year-old black and white picture. That young child is having what a beautiful smile on her face as she gets that puppet. And those two young people on the wheelchair, seems like they're not too sure about the puppet, but they sure are getting one. I'm sure they were happy. Just kidding. There's a contrast in the smile. There was no smile in this 1986 picture. All right, next slide, please. Thank you. Some pictures of the volunteers who cut and stitch these puppets. Again, I have posted the years on them. 2 of them are from 1976. One was, unfortunately, I couldn't find the date on it. The last one at the bottom right is 1978. The puppet faces were made of hard plastic or rubber in the earlier days. The cloth was cut in different shapes and stuck. They were glued to the puppet's face. Next slide, please. The puppets have evolved over the years, incorporating more intricate designs, ensuring that they continue to bring joy to our young patients. And you can see I have the then and now pictures of the different puppets that are being handed down to these young patients. And the last slide, please. Thank you. And how happy can the volunteers be? That first picture was just to show you how happy these volunteers were, dishing out those puppets and bonnets for the young patients. And bottom right, where it says 2014, I have circled with red. These are volunteers that are still in the Hankies and Puppets group. That's Gail and Wilma and Cause and Barbara. They still do they still make these bonnets and puppets for the patients. During COVID-19, this group was quite sad. They couldn't come in and do what they were supposed to do, which they really enjoyed, just hanging out with each other and making and stitching these things. not because we weren't allowing them to, because they could keep their 6 feet distance and do it, but because they were not handed out to the patients. We had stopped giving things out. We are slowly coming back, and they are doing much better. They are happy. They meet every other week. And if you have an urge to see what they do and how much fun they have, please do come and check them out on Mondays. They are here at 10 o'clock in the volunteer service office. Thank you, Sri, for the slides. And you can go back to the screen now. I can show everybody some live samples of the puppets that you saw. This was one of our earliest puppets. Hello, everyone. She's a little shy. She's looking that way. I don't know why, but that's our puppet. This one looks like was made for Halloween. She has the Halloween one on. One of my favorites, she has these little fringes. And lastly, this one. Oh. I know, these one. I know, because jokers are not well liked these days. I don't think they are giving jokers. We now give these ones out. Some of these out. We have elephants and koalas and penguins and all kinds of animals that are given out to our young patients. So those were the live sample puppets that you saw on the power slides. And we still have the cardboard cutouts from yesteryear that they used as on the clock to draw and as sample to cut them out, which is kind of amazing. And lo and behold, I found an old face and I was wondering how they did this, and I found a plastic cup that was cut and inserted in so it doesn't collapse and retain its shape, which I thought was amazing. Anyway, this journey through the history just emphasizes our singular purpose for at least us volunteers, and it perfectly aligns with our patient-first ethic to find ways to brighten the lives of our patients who visit our hospital. So that's the end of my presentation. Please let me know if you have any questions.
Thank you very much, Vijay. That's fun to see those puppets.
Yes.
I just have one other comment to make about the jewelry sale, the $5 jewelry sale. My wife bought a necklace with a pendant on it at that jewelry sale. I think it was last year or the year before. And wherever we go, honestly, wherever we go, she gets tremendous comments on this jewelry, and everybody thinks it's a very expensive jewelry.
And you don't see anything, you don't see otherwise.
I never ever say anything that casts any doubt.
I hope she doesn't get mugged.
There's no telling.
Yeah, your starting statement scared me a little bit, Dr. Stewart. I was wondering if you're going to pose. I bought it last time and it broke as soon as she wore it. I was just afraid. I was ready to answer that question, but I'm a gal who likes to shop at Ross and look like Neiman Marcus, so I'm so glad that $5 jewelry looks like it's very expensive.
I appreciate the jewelry sale, at least this pendant. It's a wonderful thing. Anyway, thank you very much. We're looking forward to that again.
Thank you, Dr. Stewart.
Bye.
Okay, now we're ready for the quality report.
Yes, we have Mary Boron, our Chief Quality Officer, is going to present the quality dashboard for quarter ending September of 2023.
Good evening. Thank you, Kimberly. Yes, I'm going to be presenting our quarter ending for September, which of course is July, August, September data for the quality department. We overall had a great quarter. There are 16 metrics in here, all met goal except for one of them. So it's a great reflection of a lot of good work going on at the bedside. Starting off with our infection prevention indicators. We have our hospital-acquired MRSA, which, as you know, is a very difficult infection in the blood to treat. And we did have one this quarter. It is still less than predicted for a hospital of our size and type. And we had gone, as you can see, about 5 quarters without an MRSA bloodstream infection. But even one, we do a root cause analysis on. This was in a chronically ill patient with multiple comorbidities. We always look at opportunities for improvement around hand hygiene and ways of preventing transmission of MRSA. Again, though, still overall doing really well with this metric. And then moving into our catheter-associated urinary tract infections, otherwise known as CAUTI. This, as you probably remember, has been a struggle for us in 2022. And in 2023, we've really seen a lot of improvement on this. This quarter, again, we have 0 CAUTIs. Our hospital was predicted to have at least one of these infections. What we've done around this is really a collaborative team effort around making sure our Foleys are removed when the patient no longer needs it. And if a patient does need it, that we're doing daily maintenance and taking really good care of this Foley while the patient has it dwelling. And I think we're starting to see some great outcome data related to that. And that story continues with our central line associated bloodstream infections, otherwise known as CLABSI. Very happy to report that we are, again, have another quarter without any CLABSI. So we're continuing even past September to see this success. Right now, we are at 540 days without a CLABSI. That's a year and a half, obviously a little bit more than a year and a half, or a little bit, just about a year and a half. And this is really just a bunch of frontline staff working very closely to maintain the central line that the patient has, make sure that the dressing is in place, and again, working with the medical staff that if a patient doesn't need a central line, getting it removed right away. We have our infection prevention staff working to educate and round on ways to keep CLABSI levels as low as we see them here. So again, just a multidisciplinary effort that we hope to continue to have this success, but it's a significant achievement for this team, but most of all is great for the patients to avoid this type of hospital-associated infection. And surgical site infections, another quarter, 6th quarter in a row with not having any surgical site infections in the colon, which is a high-risk procedure for developing surgical site infections. It's one of the reasons why this is a mandated metric by the federal government, and we've continued to do really well on this. This is a reflection of great adherence to surgical prevention guidelines in the OR, how we turn over our ORs, how we clean them, et cetera. All of these things all lead to surgical site infections. And so just really great emphasis on how we do our surgeries here at Washington. And the same continues with our abdominal hysterectomies, another requirement because it's a high-risk procedure for surgical site infections. And we have, again, our 6th quarter in a row without having any of our patients who have hysterectomies have a surgical site infection. And it's really an indicator of all the things that I mentioned before with the colon. So great work from the OR and the post-op team. C. diff is another infection that's very difficult to treat. It's a spore in the gut, and this is something that we have been historically had some challenges with, but we're well away from that now. For the last couple of years, we've typically had much lower than expected. That continues with this quarter. We had 2 hospital-associated C. diff infections. We were expected to have closer to 9 to 10 infections, and so again, this is much lower. This requires a lot of collaboration with the frontline team. Patients that come in and are at risk for C. diff, or we think they have some symptoms, they would be isolated right away to prevent C. diff from being transmitted throughout the hospital. So we do not have a transmission-based problem. In addition to that, we have been working really closely with the lab to make sure that we're doing appropriate screening guidelines for the CDC guidelines. And we have a very strong antimicrobial stewardship program. We prescribe our antibiotics here very carefully and appropriately. This is one of the ways you can measure the outcome of that, and it's fair to say that all that is the case because if you look at these outcomes. So great work to that team also. Our hand hygiene is another thing that we've continued to see for the third quarter in a row, an increase in our rate of hand hygiene compliance. Hand hygiene, of course, is the number one best way to prevent the spread of infection. We are at a 92%. That is actually better than our Joint Commission goal of 90% and the World Health Organization goal of 70%. I think that this has been something that the Patient Safety Committee has been working on a great deal with infection control and with frontline staff helping us do observations and doing education at the time if any non-compliance is observed. They've really made this a priority, and we can see the results of that with this 92% success. Our nursing sensitive indicators, another great quarter for them. Our injury fall rate is lower than expected at 0.38. The benchmark would be 0.61, and this is calculated per 1,000 patient days. So again, less than expected, and this is a reflection of 5 falls over a quarter, so just a couple of months. Any fall matters to us, even though we are having less than expected. All these falls get detailed root cause analysis reports. The team takes them very seriously, and if you have less than expected, it's really a reflection of making sure your patients are appropriately placed on units to where they can have high visibility if they're high risk for falls, frequent rounding from the healthcare workers that take care of the patients on these floors, and making sure we put bed alarms on, these sort of things. So all of that is working with this bundle approach and keeping our patients safe. Same with hospital-acquired pressure ulcers. Some people may know of these as bed sores, and we have, again, had a little bit of an increase here, but still are below the benchmark. This is only a reflection of actually one pressure ulcer. It doesn't take much to bump you up on this one. And it was sort of a deep one in a very sick patient. Critical care staff is taking this seriously, doing more education and rounding. But even to keep below benchmark is really a reflection of having the appropriate beds and mattresses for these patients, monitoring their nutrition, making sure that patients are moved appropriately if they can't move themselves, and another great outcome. This is all a reflection of sort of our magnet status and as a hospital that has great nursing care. Moving into our readmissions, I'm happy to report we only have one metric this quarter that did not meet goal, and that is this one with patients who came to the hospital to have an AMI, otherwise known as a heart attack. And we did have 2 patients return within 30 days of being discharged, and that's put us at about 20% because the number is low out of 10 patients, 10 Medicare patients. And so that's higher than the CMS benchmark, which is 14%. So these 2 patients were both chronically ill, both over age 75. They did go home with home health, and they were observed by home health closely. And because of other multiple issues going on that weren't related to this, they were recommended to come back to the hospital. And we always admit patients who, of course, meet medical necessity and have to be here. One of these patients, unfortunately, did pass away, and the patient was so chronically ill that it was sort of an expected mortality, and we were able to provide the patient with good quality care while they were here and not having the family manage that at home, which was the preference in this case. So we're going to be working on this with readmissions, but also continue to see that this is probably one of our hardest groups, because you can continue to see that it's been over the benchmark for a bit. Pneumonia has decreased, and this has been an area that it had been kind of up above the benchmark for the last couple of quarters. Our readmission rate was 14%. CMS benchmark is about 17%, and we did finally get this under the benchmarks. This reflects a total of 6 patients in the quarter coming back. We do have a dedicated transitional care nurse who prioritizes pneumonia because we've had issues with it, and these patients really need a lot of post-discharge support. So we have the transitional care nurse calling the patient within 3 days of discharge. We also have a pharmacist calling these patients to make sure that their medications are being managed well. Very important in the case of a pneumonia, that the patient is going to go see their doctor shortly after being discharged from the hospital, typically within 7 days. Do they have transportation there? Do they need home health? These are all the things that we look at and we work with to make sure that patients have a lower risk for being readmitted to the hospital. Heart failure did see a decline in this. It's actually a pretty significant decline where had 8 patients readmitted over the quarter, putting us at 13.8%, lower than the CMS benchmark. Heart failure is another really difficult chronic illness to manage. Patients do frequently come back into the hospital. And so we've been taking the same approach that, of course, we've been taking for the other groups, as I mentioned, with pneumonia. And I think we're able to see some of those results from that work that we're doing around that. Chronic obstructive pulmonary disease, otherwise known as COPD. We did have 2 patients come back in this quarter, giving us a rate of 16.7. It is lower, though, still than the CMS national benchmark, which is 19.3. These 2 patients that came back were patients that had home health, and then one had gone to a SNF and come back. So we did follow these patients closely again after they were discharged to make sure that the things that brought them in, we did see some opportunities for improvement on this, and it was related to the follow-up appointment. And so we're working closely with family members to make sure that follow-up appointments are set up and there aren't any barriers. And as I mentioned before, one of those typically seems to be about transportation, getting the patient there. We've been working on areas around that to improve. But again, under the benchmark, luckily. Coronary artery bypass graft, otherwise known as a CABG heart procedure. Happy to report 2 quarters in a row, we had 0 patients come back out of 4 patients that had CABG. And this obviously puts us at 0%, which is far less than the CMS national benchmark of 11%. The same applies with our elective primary total hips and knee replacements. We have had the 3rd quarter in the row where we have not had any patients come back. So when you look at this, it seems like, 13 is the index discharges, meaning that are basically our denominator is 13 patients, which is small. But the reason why I want to point it out is because it's what you're looking at here is only Medicare patients. We have a very large service line on this, and you have to be inpatient to get into this metric. And so if you're inpatient and you have this procedure, which is typically done as an outpatient, if you're inpatient, it's because you're a little bit sicker. And so we like to keep those patients here. They're a little bit higher risk for complications, like to monitor and watch those patients. In this case, it was only 13 for that quarter. But luckily, that care was managed very well, and we had 0 patients return. But on the next slide, you can see that we also do have great outcomes, even if you look at where the majority of our service line hits, and that is in outpatients who have their knees and hips replaced. We only had 1 patient come back out of 357 patients that were discharged. I think everybody recognizes that this service line is well known for having excellent quality of care. Readmissions is another way to measure that. And in this large population, everything was ran so well and planned ahead of time because it's an elective procedure. And that worked out with a great outcome where patients were able to go on, recover, return to their lives after their surgery without having the complication of having to come back to the hospital. Great work to that team. And those are all of my metrics. I'm happy to answer any questions. Thank you.
Any questions?
Just a comment. It's just great to see that the county occurrence rate has dropped a lot. I know that was a very difficult problem to deal with, so I'm glad to see progress with that.
Absolutely. Thank you.
Thank you again, Mary.
Thank you.
Actually, wonderful report. Very.
Yeah, thank you. A lot of work from a lot of team. Yep, lots of teamwork.
In all areas.
Good. Anyway, thank you again. We're ready now for our finance report. Tom?
Thank you. I'll be covering September's results, final results. September 23 was a soft month from a volume standpoint. However, some items of note. Discharges were unfavorable to budget by 63.
Tom, why don't you wait a second? We're just got to pull up the slides.
Oh, sorry. put my... Discharges were unfavorable to budget by 63, driven largely by a lower number of surgical patients. Patient days were under budget by 224, driven by 27 less days in ICU. IMC had unfavorable numbers by 45, and telemetry was off budget by 41. Those were the major contributors. Outpatient observation equivalency days were up significantly from the prior month at 417, unfavorable to budget by 150, and unfavorable on a year-to-date basis, or excuse me, fiscal year-to-date basis of 355 days. Moving on to the next page of operating indicators. Our case mix index was pretty close to being on budget for the month and for the quarter at 1.59 versus a budget of 1.594. Cath lab cases were unfavorable to budget by 15 for the month, and for the first quarter, we are off by 41 cases in the cath lab. Outpatient visits were unfavorable to budget by 204 for the month of September and by 374 for the first quarter. This is primarily driven by lab results, which was off about 10.7%. Emergency department was unfavorable for the month of September by 103, and for the year, they're about 600 off. Deliveries were favorable to budget by 21 for the month of September on 142 versus a budget of 121. Surgical and cath lab cases, we had favorable variance in joint replacement and other surgeries. Joint replacements outperformed the budget by 15, and other surgical cases were 157 on a budget of 156. This was offset by underperformance in the neuro, cardiac, and endoscopy areas, which were off by 6, 5, and 5 from budget. In the cath lab cases, we were off by 15 total, and we were unfavorable as where we were off were in the higher dollar revenue cases. From a productivity standpoint, September's blended productive FTEs were net unfavorable to the fixed budget by 11.6. Overall, we were looking for an FTE against the flex budget, but the flex budget was off by 44. September's blended non-productive FTEs were also unfavorable by about 11.8, so pretty close to the productive. Total blended, we were off by 23.4 for the month of September. FTEs per adjusted occupied bed, 6.24, better than budget by 11 basis points. And for the quarter, we are better than the budget by 0.21. Moving on to summary of total deductions, our contractual allowance was favorable to budget by $2.1 million, despite a weaker payer mix. Provision for bad debt, however, and charity were higher than budget by about $406,000. And so our provisional bad debt was 2% on a budget of 1.79, which brings the total reduction or deductions to 75.94, slightly better than budget at 76.94. Our summary of operations under the GASB P&L, and again, GASB stands for the Governmental Accounting Standards Board. Gross patient revenues were slightly favorable by $243,000 in the month of September. Our unfavorable payer mix is offset by supplemental funds recognized during the period. As a percent of revenue, is favorable to budget at the 75.94 versus the 76.94. Our net operating income or loss was 826 for the month on a budgeted loss of 1,049,000. Year to date, our net operating income is a loss of $5.4 million on a budget of a negative 1.8, bringing our variance to about 3.6 million. Operating expenses were unfavorable to budget by 1.1 million due to higher salaries, employee benefits, renewal of insurance policies, and utilities. Non-operating income includes $2 million for the bond issuance cost. As you know, we went to market in August for the revenue bonds and the government bonds, and GASB and FASB both require us to recognize the cost of issuance in non-op expenses. So we did that, and then this was offset a little bit by the $1 million under the federal grant revenue. This is FEMA reimbursement for certain expenses for us, and then a $900,000 recognition for the ROC JV under equity investments. This brings our non-op income to a negative 1.3 on a budget of negative 610,000, or a total net income for the month of a negative 2.1 on a budget of negative 1.659. Now we look at the same on a FASB for the Federal Accounting Standards Board. For the Federal Accounting Standards Board, reporting unrealized loss on investment, net interest expense on the GO bonds, and property tax revenues are removed from the report. So again, here, net operating income, instead of being 827 negative, is now 1.4, almost 1.5 million negative, on a budget of 1.6. And then moving down, you'll still see the cost of issuance and the FEMA and the equity and interest in the ROC. And then finally, net income, a negative 1.8 on a budget of negative 1.87, so about 41,000 favorable. And then the net income under FASB would be 6.5 negative on a budget of 3.2, leaving us 3.3 off budget for the year. The one thing I will call out on this one is under the expenses and gain loss, you'll see a gain loss on disposals, the last line, above net operating income of 204,000. This represents a disposal. We were able to trade 3 Philips ultrasound machines in at a value higher than what we were carrying it on the books. So that's a credit. And then my last slide is on the GASB EBITDA calculation, and you'll notice for the month of September, basically 2.2 million in EBITDA on a budget of 2.1 for favorable 63,000 for the period. Year to date, we're at 3.9 on a budget of 7.7, leaving us 3.76 off budget on EBITDA. Our EBITDA margin is 4.6 for the month, which matched the budgeted number of 4.6. Year to date, we're at 2.9% and on a budget of 5.5. Most of that difference is due to salary, wages, insurance, and utilities, just like I mentioned. And with that, I'll conclude my report.
Tom, I have a question.
Yep.
You mentioned that contractuals were favorable in September?
75.94
Yeah.
versus the 76.96.
But you said we had an unfavorable payer mix.
So the overall contractual rate was favorable, but it was in the government space than we would like to see than the commercial space, and that's where my comment was.
Okay.
So slightly more governmental, but we were getting Medicare, not Medi-Cal. So Medi-Cal had gone down.
That makes sense.
Yeah.
Okay. All right.
Good question. Thank you.
Any other questions for Tom? Good, thank you. move on to the operations, preliminary operations.
Right. I'm going to give this evening the operations report for October. A couple of things I do want to say. We do have a large variance in gross revenue, and we're still following up on a number of open items that we have in terms of some of the gross charges. So we expect that this number will change, but it does give still an overall direction as to some challenging areas that we're having. The other thing you'll see is for October, we've really started to ramp up the budget in terms of really wanting to demonstrate some of our initiatives in terms of volume numbers, and those are taking longer than we had hoped. But those are just a couple of things in terms of starting with October. So you can see that the patient gross revenue of $192.8 million for October was unfavorable to budget by $18.6 million or 8.8%. And it was higher though than October of 2022 by $1 million. So you'll see that we're doing around the same or a little bit better than a year ago, but again, we're still not meeting our budgets in terms of that gross revenue. In the outpatient gross revenue of $90.1 million was favorable compared to budget by $8.7 million or 10.7%, and 19.4% higher than October of 2022. Next slide. Moving on to our key census statistics, our average length of stay of 5.22 was favorable to budget by 5.26 by 0.04, and the average length of stay was higher than the October 2022 length of stay of 5.20. Observation equivalent days at 358 were unfavorable to budget of 284 by 74 equivalent days or 26.1%, and more than October of 2022 by 98 equivalent days or 37.7%. I think you saw in September we also had a very high number of outpatient observation days. We do have a task force that is working on that and looking to make sure, and it's really looking to ensure that we're putting our patients are put in the appropriate level of care, whether that's an outpatient or an inpatient observation. So we do have a whole team that is working on that right now. Our inpatient average daily census of 145.8 was unfavorable to budget of 164.5 by 11.4%, and lower than October of 2022 average daily census of 150.1. Overall, the combined average daily census of 157.3 was unfavorable to the budget of 173.7, and 0.7% lower than October of 2022 average daily census of 158.5. Moving on to our discharges, this is where you can see we have discharges of 855 were unfavorable to budget of 969 by 114 or 11.8%. And also in terms of October of 2023, discharges were 7.6% less than October of 2022. And you'll see really a lot of that's driven by patient days and some of our also decreases in some of our cath lab and other areas. So moving on to patient days trends, you can see 4,521 were unfavorable to budget of 5,099 by 578 days or 11.3%. Patient days were 2.9% fewer than October of 2022. Where we saw the greatest variances was in ICU days. There was 24% variance to budget. Outpatient or OB, peds, and special care nursery days were down 19.2%, and then our adult surge days were down 11.1% in terms of patient days. Our surgical trend, total surgeries in October of 480 were consistent with the budget, and they were 13 below October of 2022. Our inpatient surgeries at 185 were unfavorable to budget by 29 or 13.6%. And outpatient surgeries at 295 were favorable to budget by 29 and 10.9%. So had less again of the inpatient. If we turn looking at the surgical activity broken down, you can see that our joints continue to be busy, and we're favorable to budget by 9.6% or 16 cases, and we're 21.2% more than October of 2022. Our neurosurgery cases were favorable to budget by 2 or 7.7%, and were 8 or 40% more than October of 2022. Our cardiac surgical cases were unfavorable to budget by 7 or 46.7% and were 7 fewer than October of 2022. I do want to just say that our structural heart cardiologists, we do not, at this point, we have had to push out our cases until December, so that is also what is making up some of the challenges in the cardiac cases. So that we have rescheduled to December for those structural heart cases, otherwise known as our TAVR cases. Endoscopy cases were unfavorable to budget by 2 or 1.9% and were 1 fewer than October 2022. And then lastly, all other surgical cases were unfavorable to budget by 5.4% and 10% less than October of 2022. Moving on to cath lab, you can see that our cath lab cases for October came in at 173 that were 21.4% unfavorable to budget. We did have a budget of 220, but they were 2.3% less than October of 2022. I did go back and look at again, as you saw, previous months. September was 165 in terms of cath lab cases. August was 193, and July was 149. So this month was 173. So we did a little bit better, but still we had increased the budget. Hoping that we'd have the full complement of physicians. We did have a vascular surgeon that just recently started at the middle or beginning of October, so that physician is just starting to ramp up. So, moving on to our cath lab activity, you can see it broken down in terms of the different types of cases. Basically, in terms of being under budget, with non-vascular IR cases by 23%. And peripheral vascular cases by 48.3%. Also, neuro IR cases were under budget at 5 compared to a budget of 10 or 50% in terms of that. Moving on to deliveries, we came in at 121 deliveries based on a budget of 129, so a 6.2% variance. I will say we continue to see the ups and downs in deliveries. We had C-sections that came in at 40 or 33.1% of total deliveries. Moving on to our non-ER outpatient trend, our outpatient visits came in at 9,062 that were favorable to budget by 168 or 1.9%, but were 0.9% fewer than October of 2022. This was primarily driven by our imaging services that was 14% favorable to budget, and cardiac rehab that was 18.9% favorable to budget, and then offset by lab, again, that was down 9.4%. Many of that is due to the COVID visits that we had budgeted at that time. Moving on to emergency room visits. Emergency room visits came in at 5,065 that were unfavorable to budget by 54 or just 1.1%, but were 95 or 1.9% more than the prior year. So still we've seen a pretty large visits coming into the emergency room. Then moving on to the gross revenue recap, as you can see, surgical services were consistent with budget in terms of the volume, but revenue was unfavorable by 3.4%, and this is really due to less cardiac cases and other surgical cases that inpatient surgeries. The biggest variances, as you can see, is with room and board and ancillary services revenue that was unfavorable to budget by 13.7%. Really, that's driven by the less patient days and discharges that was offset by increases that we saw in the outpatient surgery services. And then the other piece that really is driving this below budget is cath lab services. And again, cath lab was $3.7 million unfavorable to budget, just given, as we said, cases were unfavorable to budget by 21.4%. Looking at our preliminary payer mix, our government payer mix sponsored patient revenue made up 74.8%, so we saw an increase. especially as you can see in the Medicare payer mix, and it came in at 55% versus a budget of 50.7%. So total government sponsored came in at 70.8% versus a budget of 72.2%. HMO came in at 2.5% versus a budget of 2.3%. Unfortunately, we saw a decrease with PPO that came in at unfavorable to budget at 20.8% versus a budget of 24.1%. And lastly, private pay did come in higher at 1.9% versus a budget of 1.4%. Moving on to the productivity indicators, productive FTEs were favorable to budget by 10.6 or 0.7%. Non-productive FTEs were unfavorable to budget by 28.6 or 17.8%. So total FTEs were unfavorable to budget by 18%. Our total FTEs per adjusted occupied bed came in at 6.03, which was favorable to budget of 6.11 and favorable to the prior year that was at 6.4. So continuing to make some effort in terms of that, but still we're working on continuing to decrease our FTEs and align with our budget. In terms of the outpatient statistics, witness clinics came under budget by 9.9%, that were higher in October of 2022 by 1,574 visits. We have two things that are really driving this. We've got a number of open physician positions in primary care, nurse practitioners, and also in orthopedics that was driving that. Along the other area was we did have a number of physicians take time off. So those were the two things that were driving the clinic visits. In terms of vaccine, also, we really focused all of our flu clinics in September, and so we didn't have that many really in October, so that was where we had centered the time in September. Also, this number we had budgeted to do our COVID vaccines, but now we've partnered with Hallers, and Hallers is really is doing those COVID vaccine clinics for us now at this point. Looking at our Development Corporation visits, they came in at 2,386 that were favorable to budget by 17 for October and 19.9% more than October of 2022. Really, most of the clinics and the centers came in on budget or over budget. WASC was unfavorable to budget by 8.1%, and again, we had a number of physicians that were out took time off, and that was also driving the surgery center volume to be lower than budget. Radiation Oncology Center also came in lower than budget. We had one of our medical oncologists that was on family leave for a period of time, which reduced the number of referrals for our radiation oncology. That we do have a number of patients now in the queue for treatment, so over the next couple of months we'll see that ramp back up. And we also had some with accreditation planning too that was happening. Moving on to days cash on hand, we did see a decrease and ended at 127 days. This was due to a couple of pieces. First, we had to do an intergovernmental transfer for supplemental revenue. As you know, this is where we do send money to the state and federal level, and then they send it back in terms of additional dollars. So we see that in revenue coming. We also had a number of capital outlays for some of the construction projects that we'll be able to use general obligation bonds also to fund those capital outlays. Our days in accounts receivable in October were 57.8. This was a 0.1 day more than the prior month, but was 3.7 days shorter than October. There were $312,000 in charity care adjustments for October of 2023. So I know there's a number of things we need to follow up on and initiatives that we need to focus on. And again, not only looking at our areas to increase our revenue in terms of our service lines, knowing that, but also continue to look at decreasing our costs. So those are two areas that we know that we need to focus on. So.
Any questions? Okay. Kimberly, our healthcare system calendar.
Yes, I will go over the health promotion and community outreach events for October. Go to the next page, and I'm just going to highlight a couple of these. As you know, October 14th, we had our annual Top Hat Gala. We had over 600 attendees, and it was a very successful event. Also, that same week, on October 19th, we hosted our 15th annual Think Pink breast cancer awareness event and had over 280 attendees for that. And you can see we had many other community outreach events in the communities or in Washington West. Moving on to the next page, you can see that a number of our physicians were busy giving health promotion events and talking. We had Dr. Lynn, he's a family medicine practitioner who was at Cottonwood Place in Fremont, who spoke about how diet affects diabetes and blood pressure. We also did our sports physicals at Irvington High School. We had a number of our physicians, Dr. Nord and Dr. Golden and Dr. Harpreet Singh, that all completed about 81 sports physicals, and we donate that money back to the schools, both Fremont Unified and Newark Memorial High School. And we did, yes, 81. Moving on to the next page, you can see also continue to support the schools. We were at James Logan High School for a job expo where there were 110 people that participated in that. We were also at Irvington High School Synapse Club, and then you can see that Dr. Dearborn talked about same-day discharge after total hip replacements on Facebook Live and YouTube, along with in Anderson Auditorium. And lastly, on November 5th, we had the Aruna Foundation Walkathon, and that Washington participated in at Quarry Lakes, too. Then we just have a couple of pictures that you can scroll through. Our participation in the community, a lot of those that we've talked about in the past. And then just coming up in November, we have a number of health promotion and community outreach events, and these are all can be found on our website in terms of looking at these events and where they are, and if you want to see them through Facebook Live or YouTube. And you can see that we have a number of our physicians participating in those. You can move on to those for December. Also, we're hosting a tattoo removal clinic in Washington West. Also, Dr. Mather, our OBGYN with the Medical Foundation, is going to give a Facebook Live and YouTube talk on pregnancy after age 35. And you can see we're going to be holding our tree lighting celebration in Anderson Auditorium. Just again, want to thank everybody that attended our Top Hat. We grossed over $1.15 million in terms of gross and netted over $730,000+ through this event, all going to our cancer center. So very excited about that. We do want to just recognize on November 28th, the foundation will participate in Giving Tuesday, and donations raised will fund specialized trauma readiness training for nurses and our clinical staff. And then lastly, as I mentioned, on December 6th from 5 to 7 p.m., we will have the holiday tree lighting celebration in Anderson Auditoriums, and also with a visit by Santa and Mrs. Claus, too. So. And that is my report. We do not have an Employee of the Month that is happening later on this month. In December, we will have 2 of those recognitions, both November and December.
Thank you, Kimberly. We're now ready to move on to our action items. So we have already acted on item A. That motion passed. That action item passed. I'm ready now for motion on item B.
Mr. President, I move for the adoption of budget amendment for fiscal year 2024.
Second.
We have a motion and a second. Kimberly, if you'd like to explain that.
Yeah, this budget amendment is driven, focused on our relationship with our anesthesiologists. It's been a very challenging year in terms of retaining and recruiting anesthesiologists. The costs involved in that have continued to increase, and it's a partnership that we have with our anesthesiologists. And it's important that we have strong anesthesiologists that are aligned with the healthcare system. So we've agreed in terms of for this next year to increase the stipend by $3.4 million for the remaining of the year. So we're just doing a budget amendment to reflect that.
Any other questions on that? Cheryl, if you take the roll.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Yee,
Aye.
Director Epen.
Thank you. That motion passes. We'll now move on to a consideration of resolution number 1258, memorandum of understanding between Washington Hospital and SEIU.
President, I move for the adoption of resolution number 1258, memorandum of understanding between Washington Hospital and the United Healthcare Workers West, SEIU, CTWCLC.
I'll second that.
We have a second. Kimberly, do you have anything to add on that? I know that we're all keenly aware of what's happened there.
We're all very well aware. Happy to bring forward to you this 3-year agreement, and it covers over 50 different positions throughout the hospital, including our EVS workers, dietary workers, supply techs, respiratory therapists, surgical techs, unit clerks, and CNA. And it's the terms are listed in the memo that we provided in terms of wage increases, also different differentials. We've made some changes with hours worked as needed, the benefits, educational leave, leave absences, and also the respiratory care, professional development, career ladder. So all of that's outlined in the memo.
It's nice to have that done. It truly is. Cheryl, if you take the roll on that, please.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Yee,
Aye.
Director Epen.
Thank you very much. Nice to have that passed. Move ahead. Move ahead. Now, there being no further business this evening, this meeting is now adjourned.